Yeah. So what needs to change is that we really need formal training programs for infection preventionists. I've been trying to do this for years. Um, I've been trying to get a curriculum embedded in Masters of Public Health programs. I went to one school in particular. It was kind of enlightening how they did not really respect our profession and understand. I think we need bachelor level or master's level public health and nursing schools to offer a track in hospital infection prevention. I've worked with APIC over the years to write the curriculum. APIC does have a curriculum that I worked on to lay out what needs to be taught. But I really believe that this needs to be a track that people either get as an undergraduate or part of their master's. I see it as a master's in public health in infectious diseases, which we have now at a lot of schools. And that 1 year is classroom and has to do with epidemiology, and most of that coursework is already there. And the second year is internship in a hospital, so that when you finish, you're a confident infection preventionist. And this is where I see the future, what I would love to see in this country. It is such a complex profession. It's not understood. Even the universities that I spoke to did not understand, because yeah, you can be academic and theoretical. We need practical. We need practical, but we need people who are trained in theory, understand why they're making these decisions. You need to understand the theory behind all of these, the transmission of diseases. And so I feel like that's where we need to go. But in the meantime, we need formal training. And when, I know from feedback I've gotten from people about the formal training, over the years, it's just been a checklist. We've onboarded infection preventionists, and I think 99% of the country, that's what they do. They got a checklist. Someone goes through that topic with somebody and checks them off. But do they ask them to demonstrate that they understand how to apply the concept? Is there an exercise that they can put in there for them to show me you actually understand how to apply the concept I just taught you? That is not happening. And that's what needs to change. It's not that hard, but somebody has to take the time to put together the exercises that they would want to demonstrate. For instance, like I said, you can put in their risk assessment and you can say patient comes into the hospital with these symptoms. Okay. And now this patient ends up having meningococcal meningitis. Okay. What do? What is the first step? Okay. Same thing with, you may have a bunch of patients who have surgical site infections after they've had laminectomy. Where do you start? Where do you start? And just ask them that. Tell me step one. Where are you going to look if you think maybe you've got a problem? That's what we don't ever do. We don't ever make sure they're competent before we let go of them. And competency has been a big issue for infection prevention in this country. Over the years, Joint Commission would always ask for, we need to see your IP's competency. And we'd say, well, there's nobody who can judge. We're the specialists. Nobody knows our field better than we do. How do we self-judge? I don't know how to do a competency. Okay. But over the years, we've done that. At my organization, we have very robust competencies I've worked on that exactly do that. Ask, what do you do step one? What do you do step two when you are presented with this scenario? What do you do and why? And that's what we need to do. More practical onboarding of making sure before we let somebody go that we didn't just tell them what chapter to read in the APIC text, but that we actually know how to apply, that they know how to apply the concept that we ask them to read about.